There is a mineral that your heart muscle cannot function without, not function well, cannot function at all. Every single heartbeat you have ever had, every contraction of the cardiac muscle that has kept you alive from the moment you were born until this exact second, has depended on this mineral being present in adequate amounts inside the heart muscle cells. When it is present in adequate amounts, the electrical signals that coordinate each heartbeat travel correctly. The chambers contract in sequence. The heart rate stays stable. The blood vessels remain appropriately relaxed. When it falls even modestly below optimal levels inside the cells, the electrical system of the heart becomes unstable. Arrhythmias become more likely. Blood pressure rises. The coronary arteries are more prone to spasm. And the heart muscle itself, working against greater resistance with less efficient chemistry, fatigues faster and recovers more slowly. The mineral is magnesium. And what makes this a genuine crisis of public health rather than a nutritional footnote is the following fact. Approximately half of all adults in the United States are not getting adequate magnesium. In people over 60, that proportion rises to somewhere between 60 and 70% depending on the population studied. And your standard annual blood panel, the one your physician orders, the one that comes back and is described to you as normal, does not measure magnesium where it actually matters. It measures it in the wrong place. And almost nobody is telling you this. I am Dr. David Miller. I have been practicing medicine for 15 years, and I built this channel on one principle. The gap between what the research shows about cardiovascular health and what the average person is told in a clinic appointment is wide enough to drive a preventable heart attack through. Magnesium and its relationship to cardiac function is one of the clearest examples of that gap I know. Subscribe to Dr. Miller right now and hit that like button. We are building a community of people who understand their own cardiovascular biology. Every subscriber makes this channel more visible to the next person who needs it. Let me tell you about a patient I will call Arthur. He was 69 years old. He had a history of atrial fibrillation, an irregular heart rhythm, that had been diagnosed 3 years earlier and was being managed with an antiarrhythmic medication and a blood thinner. He came to see me not because his cardiologist had referred him, but because he had been reading about magnesium and cardiac function and had asked his cardiologist about testing his magnesium levels. His cardiologist had ordered the test. The result came back at 0.87 millimoles per liter. The laboratory reference range listed normal as 0.75 to 1.0. His cardiologist had seen the result, noted it was within normal range, and told Arthur his magnesium was fine. Arthur was not satisfied. Something about the explanation did not sit right with him. He came to me and asked me to explain what the test actually measured and whether fine was the right conclusion. It was not the right conclusion. And the explanation of why it was not the right conclusion is the central piece of information in this video. Less than 1% of the total magnesium in the human body is in the blood. The remaining 99% is distributed inside cells, primarily in muscle tissue, including cardiac muscle, in bone, and in other soft tissues. The Serum Magnesium Test, which is what was measured in Arthur's blood, measures that less than 1% fraction. It is the fraction that the body regulates most tightly and most aggressively because magnesium is so essential to cellular function that the body will pull it from intracellular stores and from bone to maintain the serum level within the reference range. This means the serum level stays normal until the intracellular reserves are so depleted that compensation is no longer possible. By the time the serum magnesium falls below the reference range, the person has been in a state of significant intracellular magnesium depletion for months or years. The serum test is the last number to change, not the first. Arthur's serum magnesium at 0.87 was within range. But it told me nothing about what was happening inside his cardiac muscle cells, which is where the magnesium that matters for heart rhythm and cardiac function actually resides. The test that measures intracellular magnesium is called the RBC Magnesium Test, or red blood cell magnesium test. which measures magnesium inside red blood cells and serves as a proxy for intracellular magnesium status throughout the body. This test is available at standard laboratories. It must be specifically requested by name because it is not part of the standard metabolic panel. Arthur had never had it ordered. When I ordered it, his RBC magnesium came back at 4.1 milligrams per deciliter. The optimal range for cardiac function, based on the research literature, begins at 5.5 to 6.0. Arthur was significantly intracellularly deficient while his serum test sat comfortably in the normal range and his cardiologist said everything was fine. I want to explain what magnesium actually does in the heart, because this is the information that transforms the abstract concern about a mineral level into a concrete understanding of why it matters for the specific cardiac conditions that affect the majority of people over 60. The electrical system of the heart depends on the movement of ions, charged particles, across the membranes of cardiac muscle cells. Sodium flows in to initiate depolarization, the electrical signal that triggers contraction. Calcium flows in to drive the actual mechanical contraction of the muscle fiber. Potassium flows out to repolarize the cell and prepare it for the next beat. And magnesium is the regulator of all of these channels. It sits at the gate of the calcium channel and controls how much calcium enters the cell. It regulates the sodium-potassium pump that maintains the electrical gradient across the cell membrane. It is the gatekeeper of the entire cardiac electrical system. When magnesium is adequate inside the cardiac muscle cell, the ion channels open and close in the correct sequence. The electrical signal propagates correctly from the sinoatrial node through the atria and ventricles, and each heartbeat is coordinated and regular. When magnesium falls inside the cardiac muscle cell, the calcium channel loses its regulator. Calcium influx becomes excessive and poorly timed. The sodium-potassium pump becomes less efficient. The electrical gradient across the cell membrane becomes unstable. And the conditions for arrhythmia, an electrical signal arising from the wrong place at the wrong time, become significantly more likely. Atrial fibrillation is the most common cardiac arrhythmia in people over 60, affecting approximately 1 in 10 people in that age group. Its causes are multiple and its management is complex, but magnesium deficiency is one of the most consistently documented and most consistently unaddressed contributors. Studies have shown that intravenous magnesium is effective in converting certain arrhythmias back to normal rhythm. Magnesium supplementation in people with atrial fibrillation reduces the frequency and duration of episodes in populations with demonstrated magnesium deficiency. And the antiarrhythmic medications used to manage atrial fibrillation, many of which are taken by millions of people over 60, work partly through mechanisms that overlap with magnesium's role in cardiac ion channel regulation. What is not routinely done is measuring the intracellular magnesium of the patient taking those medications and determining whether the medication is compensating for a deficiency that could be partially addressed directly. Subscribe to Dr. Miller and hit the like button. The role of magnesium in cardiac ion channel regulation is not alternative medicine. It is electrophysiology. It appears in the curriculum of every cardiology training program. The gap is not in the science. The gap is in the clinical practice of measuring intracellular magnesium and integrating the result into cardiovascular management. This channel exists to give you the information you need to ask for that integration. Hit subscribe. Every subscriber means the next person with an arrhythmia diagnosis gets asked about their magnesium level before being told their mineral status is fine. Now I want to explain the causes of magnesium depletion specifically in people over 60, because identifying them is what allows for targeted intervention rather than simply supplementing and hoping. The first cause is declining dietary intake combined with declining intestinal absorption. Magnesium is abundant in whole plant foods, particularly green leafy vegetables, legumes, nuts, seeds, and whole grains. The progressive narrowing of dietary variety that occurs with age, combined with the reduction in stomach acid production that reduces the efficiency of magnesium absorption, means that dietary magnesium intake and absorption both decline as people age precisely when the cardiovascular system needs this mineral most. The second cause is medication-induced depletion, and this is the one that is most directly relevant to the majority of people over 60 with cardiovascular conditions, because the medications that deplete magnesium most aggressively are among the most widely prescribed in that population. Loop diuretics, including furosemide, which are used for heart failure and hypertension, increase urinary magnesium excretion significantly. Thiazide diuretics, another common antihypertensive class, also increase magnesium losses. Proton pump inhibitors, used for acid reflux and ulcer prevention, impair magnesium absorption from the gut at the level of the transport channel and can produce profound magnesium depletion with long-term use. The FDA issued a safety communication about this in 2011 requiring warnings on PPI packaging. And yet the conversation about monitoring magnesium levels in people taking these medications is not happening consistently in clinical practice. Patients on these drugs are being depleted while their serum magnesium stays in the normal range and no one orders the RBC test. The third cause is chronic stress and elevated cortisol. Cortisol promotes urinary magnesium excretion. Every sustained period of psychological or physical stress accelerates the loss of magnesium through the kidneys. The stress of a cardiovascular diagnosis, the stress of managing a chronic illness, the stress of aging itself, these are all magnesium-depleting states that compound the dietary and medication-driven deficits. The fourth cause is alcohol consumption, even moderate alcohol consumption. Alcohol is a direct magnesium-wasting agent. It increases urinary magnesium excretion through a mechanism involving aldosterone regulation that operates independently of the amount consumed. Regular evening wine or spirits, the kind that many people consider harmless, produces meaningful cumulative magnesium losses over months and years that contribute to intracellular depletion without any corresponding change in the serum level. Now I want to address what adequate magnesium actually does for the cardiovascular system beyond arrhythmia prevention, because the effects are broader than most people understand. Magnesium is the primary natural calcium channel blocker in the human body. Calcium channel blockers are a class of medication prescribed for hypertension and angina precisely because they prevent excessive calcium influx into vascular smooth muscle cells, reducing vascular tone and lowering blood pressure. Magnesium does this endogenously. Adequate intracellular magnesium maintains appropriate vascular smooth muscle relaxation. When magnesium falls, vascular smooth muscle tone increases. Blood pressure rises. Coronary arteries, the vessels that supply the heart muscle itself with blood, become more prone to spasm. The risk of angina and in some presentations of sudden cardiac events increases. Magnesium also inhibits platelet aggregation, the clumping of blood platelets that is the first step in clot formation. Adequate magnesium reduces the stickiness of platelets and the likelihood that they will form the dangerous clots that cause heart attacks and strokes. Many people over 60 take low-dose aspirin for exactly this purpose, aspirin being another platelet aggregation inhibitor. The endogenous magnesium-mediated inhibition of platelet aggregation is working alongside or instead of that aspirin in people with adequate magnesium levels and working far less effectively in people with intracellular deficiency. And magnesium regulates the production of prostacyclin, a compound produced by the endothelial cells lining the blood vessel walls that dilates vessels and prevents platelet adhesion to the vessel wall. Adequate magnesium supports prostacyclin production. Deficient magnesium suppresses it. The endothelial protection that prostacyclin provides is one of the most fundamental cardiovascular protective mechanisms in the body, and it is magnesium dependent. The protocol I recommend for addressing magnesium deficiency in people with cardiovascular concerns has 3 components. The first is getting the right test. Request an RBC Magnesium Test specifically by name, not serum magnesium. RBC Magnesium. Explain to your physician that you are concerned about intracellular magnesium status, specifically in the context of cardiac function, and that the serum test does not capture this. The optimal RBC magnesium for cardiac health is generally considered to be between 5.5 and 6.5 milligrams per deciliter. If your result is below 5.5, supplementation is indicated. If it is below 5.0, the deficiency is significant and the supplementation strategy should be more aggressive. The second component is dietary magnesium optimization. The foods highest in bioavailable magnesium that should be incorporated daily are pumpkin seeds, which contain more magnesium per gram than almost any other whole food and are one of the most practical additions to a daily diet for this purpose. Dark leafy greens, particularly spinach and Swiss chard, which are rich in magnesium and in the cofactors that support its cellular uptake. Legumes, including black beans, lentils, and chickpeas. Dark chocolate above 85% cacao. And avocado. These are not arbitrary wellness recommendations. They are the foods with the highest magnesium content and the best evidence for improving cardiovascular magnesium status in people with deficiency. The third component is targeted supplementation, and the form matters enormously. The most common supplemental magnesium sold in pharmacies is magnesium oxide. It has the highest magnesium content by weight and the lowest absorption rate of any commonly available form, approximately 4% bioavailability. It is almost entirely useless as a cardiovascular intervention. The forms with the best evidence for cardiovascular magnesium repletion are magnesium glycinate, which is highly bioavailable, well-tolerated, and produces minimal gastrointestinal side effects, and magnesium malate, which is similarly well-absorbed and has additional evidence for supporting energy metabolism in the cardiac muscle specifically. A dose of 300 to 400 milligrams of elemental magnesium per day from either of these forms, taken in the evening when the body's magnesium utilization peaks during the nighttime cellular repair processes, is the standard supplementation target. How old are you? Write it in the comments right now. I want to see the age range of this audience because it shapes everything I produce next. If most of you are in your 60s, I want to address the interaction between magnesium and the potassium that is co-depleted by many of the same medications and dietary patterns, because the two minerals work together in cardiac ion channel regulation, and correcting one without the other produces incomplete results. If many of you are in your 70s, I want to discuss what the evidence shows about magnesium's role in preventing the progression of existing cardiac conditions at that stage, because the research on secondary prevention is as compelling as the research on primary prevention. Arthur came back to see me 4 months after our first appointment. He had been taking magnesium glycinate at 360 milligrams per evening, had increased his dietary magnesium through daily pumpkin seeds and more frequent consumption of legumes, and had reduced his evening alcohol from nightly to twice weekly. His repeat RBC magnesium was 5.8, up from 4.1. He told me that his cardiologist, at his most recent appointment, had noted that his Holter monitor results, a recording of his heart rhythm over 24 hours, showed fewer irregular beats than the previous recording 6 months earlier. His cardiologist attributed it to a slight adjustment in his antiarrhythmic medication dose. Arthur told him about the magnesium protocol. His cardiologist said he was not aware that the RBC Magnesium Test existed and asked Arthur to send him the reference I had given him. That conversation happened in a cardiology office in a major hospital system. The test that measures cardiac magnesium status at the cellular level was unknown to the cardiologist managing a patient's atrial fibrillation. The mineral your heart desperately needs was not being measured in the organ that needs it most by the physician most responsible for that organ's care. Your heart is working every second of every day for your entire life without rest. It does this on the basis of a precisely regulated electrochemical process that depends on magnesium at its most fundamental level. When that mineral is depleted at the cellular level, the process becomes less precise. The consequences are not always dramatic. Sometimes they are subtle, a slightly elevated blood pressure, a slightly increased frequency of irregular beats, a slightly reduced tolerance for physical exertion. Sometimes they are not subtle at all. The test to find out which category you are in costs less than $50 and requires a specific 4-word request to your physician. RBC Magnesium Test. 4 words that could be the most important thing you ask at your next appointment. I am Dr. David Miller, and I have spent 15 years watching cardiovascular conditions be managed with escalating medications, while the intracellular mineral status of the heart muscle was never measured and never addressed. The heart does not care what your serum magnesium says. It cares what is inside its own cells. Subscribe to Dr. Miller, hit the like button. Share this with someone who has been told their magnesium is normal and is still experiencing cardiac symptoms that are not fully controlled by their medication. Normal serum magnesium and adequate intracellular magnesium are not the same statement. And for the heart, the intracellular number is the one that matters. The healthcare system profits from managing arrhythmias and hypertension with ongoing prescriptions. I profit from you understanding the mineral that those prescriptions are partially compensating for and addressing it directly. Subscribe if that difference matters to you. This content is educational in nature and does not constitute personalized medical advice. If you have a cardiovascular condition or are taking cardiac medications, including antiarrhythmics, blood thinners, or diuretics, please discuss magnesium testing and supplementation with your physician before making changes. Magnesium supplementation can interact with certain cardiac medications and must be monitored appropriately in people with kidney disease.